Welcome everyone. In today's lecture, we are going to discuss one of the most commonly prescribed drug classes in modern medicine, proton pump inhibitors or PPI. These drugs have completely transformed the management of acid-related disorders because of their remarkable ability to suppress gastric acid secretion and promote mucosal healing. As a result, PPIs are widely used in conditions such as gastroesophageal reflux disease, peptic ulcer disease, Helicobacter pylori eradication therapy, functional dyspepsia, and gastroprotection in high-risk patients taking medications like NSAIDs or antiplatelet drugs. However, despite their excellent efficacy and overall safety profile, long-term and sometimes unnecessary use of PPIs has become increasingly common, which has consequently raised concerns regarding potential adverse effects. Over the years, several observational studies have linked prolonged PPI therapy with complications such as enteric infections, vitamin and mineral deficiencies, osteoporosis-related fractures, kidney disease, and other long-term risks. Therefore, in this lecture, we will understand the physiology of gastric acid secretion, the mechanism of action of PPIs, their clinical uses, adverse effects, drug interactions, and the importance of rational long-term PPI use. Let's first begin by discussing the normal physiology of gastric acid secretion, because this foundation will naturally help us understand how PPIs work later on. To start with, the stomach lining is not just a simple surface. Rather, it contains specialized structures including mucus-secreting cells that cover the entire surface. And in addition, two important types of tubular glands, namely the oxyntic or gastric glands and the pyloric glands. The oxyntic glands are predominantly located in the body and fundus of the stomach, that is, the proximal 80%. And this region is therefore referred to as the oxyntic gland area. In contrast, the pyloric glands are mainly found in the antral region, which forms the distal 20% of the stomach near the pylorus. The oxyntic glands play a central functional role as they secrete hydrochloric acid, pepsinogen, intrinsic factor, and some mucus. Whereas, in contrast, the pyloric glands mainly secrete mucus to protect the distal stomach and, importantly, also release the hormone gastrin. Let's see how the gastric gland looks first, because this is the main focus of today's discussion, as it is the structure responsible for secreting hydrochloric acid. So as shown in the image, the stomach wall is organized into different layers, namely the mucosa, submucosa, and muscularis externa. And among these, the mucosa is the most important for secretion. Now within this mucosal layer, we can clearly see invaginations of the surface epithelium forming structures called gastric pits. And importantly, these pits do not just end there. Rather, they extend deeper down to form long tubular structures known as gastric glands. In other words, the gastric pits act like entry points that lead into these glands. When we zoom into one of these glands, we can appreciate that it is not made of a single cell type, but instead consists of multiple specialized cells arranged along its length. For instance, mucous neck cells secrete mucus, chief or peptic cells release pepsinogen, and most importantly, parietal or oxyntic cells produce hydrochloric acid and intrinsic factor. In addition to these, there are enterochromaffin-like cells which secrete histamine and further regulate acid production. So when the parietal cell gets stimulated, this effect is produced by three main signals that act synergistically. First, there is neural stimulation via the vagus nerve, which releases acetylcholine that directly activates parietal cells. At the same time, there is hormonal stimulation through gastrin, a hormone released from G cells of pyloric gland in the antrum, which travels through the blood and further enhances acid secretion. In addition to this, there is a paracrine pathway where enterochromaffin-like cells release histamine, which then acts locally on parietal cells and strongly amplifies their activity. So when the parietal cell is stimulated, it secretes a highly acidic solution into the gastric lumen. The parietal cell contains tiny channel-like spaces called canaliculi, and importantly, these spaces are lined with numerous microvilli that greatly increase the surface area for acid secretion. Therefore, hydrochloric acid is actually formed within these canaliculi and then transported efficiently into the lumen. Now let's understand the actual mechanism that drives hydrochloric acid secretion, because this is the core step where everything comes together. To begin with, the main driving force is the hydrogen-potassium pump, also known as the hydrogen-potassium ATPase pump, located on the apical surface of the parietal cell. First of all, inside the parietal cell, water dissociates into hydrogen ions and hydroxide ions. And then these hydrogen ions are actively pumped into the canaliculus in exchange for potassium ions through this hydrogen-potassium ATPase pump. These potassium ions don't just accumulate inside. Instead, they tend to leak back into the canaliculus through potassium channels, and this allows them to be reused again by the same pump. At the same time, on the basolateral side, the sodium-potassium ATPase pump is actively working to bring potassium into the cell from the blood, while pushing sodium out, thereby maintaining a steady intracellular supply of potassium. At the same time, the remaining hydroxide ions combines with carbon dioxide to form bicarbonate, a reaction catalyzed by carbonic anhydrase. And this bicarbonate is then transported into the blood in exchange for chloride ions. Now these chloride ions, after entering the parietal cell from the blood, also move into this same canaliculus through chloride channels. So importantly, both hydrogen and chloride ions meet in the canaliculus. Here, they combine to form hydrochloric acid. So as hydrogen ions and chloride ions are continuously secreted into the canaliculus, the concentration of solutes in this space becomes very high. Now, whenever there is such an increase in solute concentration, water naturally follows. Therefore, water moves from the parietal cell into the canaliculus, and as a result, the secretion becomes a fluid rather than just ions. In other words, what ultimately enters the gastric lumen is not just hydrogen and chloride ions separately, but a fluid rich in hydrochloric acid, making the secretion both concentrated and effective for its digestive function. Now that we have understood the normal physiology of hydrochloric acid synthesis and secretion, let's finally move to our main topic. PPI are actually prodrugs, meaning they are initially inactive and require an acidic environment for activation. So after being absorbed into the bloodstream, these drugs diffuse into the parietal cells and specifically accumulate within the highly acidic canaliculi that we discussed earlier. Then, inside this acidic environment, the drug becomes activated and gets converted into its active sulfonamide form, which essentially becomes trapped within the canaliculus. Subsequently, this activated form binds covalently and irreversibly to the hydrogen-potassium ATPase proton pump, thereby permanently inactivating that particular pump molecule. Therefore, acid secretion cannot resume until entirely new proton pumps are synthesized and inserted into the membrane, which explains why PPIs produce a prolonged suppression of acid secretion, despite having a relatively short plasma half-life. Importantly, because PPIs block the final step of acid secretion, they can effectively reduce both basal and stimulated acid production, regardless of whether the stimulation comes from acetylcholine, gastrin, or histamine. PPIs work best when taken before the first meal of the day. This is because proton pumps, which secrete stomach acid, are not always active. They become more active after eating. During the night, parietal cells in the stomach prepare a lot of proton pumps. When you eat, signals like acetylcholine, gastrin, and histamine activate these pumps. If you take PPIs 30 to 60 minutes before breakfast, the drug reaches the parietal cells just as the pumps are becoming active. This timing is crucial because PPIs can only bind to and inhibit active pumps. Taking PPIs before a meal ensures the most pumps are inhibited, leading to better and longer lasting suppression of stomach acid. Finally, it is also important to remember that prolonged suppression of acid can sometimes lead to rebound acid hypersecretion after discontinuation, which may temporarily provoke symptoms such as dyspepsia. Furthermore, because not all proton pumps are active at the same time, a single dose cannot inhibit every pump immediately. Therefore, maximal acid suppression usually develops gradually over 2 to 5 days of regular once daily therapy. Now, after the mechanism of action of PPIs, let's briefly look at the different drugs available in this class. Currently, 6 proton pump inhibitors are commonly used in clinical practice, namely Omeprazole, Esomeprazole, Lansoprazole, Dexlansoprazole, along with Rabiprazole and Pantoprazole. Although these drugs differ slightly in their chemical structure and pharmacokinetic properties, they all work through the same fundamental mechanism. Therefore, when given at comparable doses, all PPIs generally produce a similar degree of acid suppression and have equivalent clinical efficacy. Now, once PPI is absorbed from the small intestine, PPIs enter the bloodstream and are extensively metabolized in the liver, mainly by CYP2C19 and CYP3A4 enzymes. Since these drugs are metabolized in the liver, severe hepatic disease can reduce their clearance, and dose adjustment may sometimes be required. Now, after understanding how PPIs work, let's look at their major therapeutic uses. To begin with, PPIs are widely used in peptic ulcer disease, especially in patients who do not respond adequately to H2 blockers, as they promote faster ulcer healing and more effective pain relief. Most duodenal ulcers heal in 4 to 6 weeks, while gastric ulcers require somewhat longer time of 6 to 8 weeks. Bleeding peptic ulcer patients run the risk of rebleeding. Higher dose of omeprazole, that is 40 milligrams twice daily, or other PPIs for 5 to 7 days reduce the risk of bleeding. They are also extremely important in the treatment of gastroesophageal reflux disease, particularly in severe cases and in patients with erosive esophagitis, where prolonged acid suppression may sometimes be necessary. In addition, PPIs are commonly included as part of the treatment regimen for H. pylori infection, since reducing gastric acidity improves ulcer healing and enhances antibiotic efficacy. Furthermore, these drugs are frequently used for the prevention and treatment of NSAIDs-induced ulcers in patients who require long-term NSAIDs therapy. However, If the NSAIDs is discontinued, the PPI is usually continued for another 4 to 6 weeks to allow complete ulcer healing before it is gradually stopped. Another important clinical application of PPIs is their use alongside antiplatelet therapy, particularly with drugs such as aspirin and clopidogrel. Since these medications increase the risk of gastrointestinal irritation and bleeding, PPIs are often co-prescribed to provide gastroprotection, especially in patients with a prior history of peptic ulcer disease or GI bleeding. Therefore, in many cardiovascular patients, PPIs play a crucial supportive role. Similarly, PPIs are also commonly considered in patients receiving anticoagulants such as warfarin or direct oral anticoagulants. Since anticoagulants can increase the likelihood of upper GI bleeding, co-prescribing a PPI may help protect the gastric mucosa and reduce bleeding-related complications. This becomes especially important in patients with a previous history of peptic ulcer disease, prior GI bleeding, advanced age, or concurrent use of other ulcerogenic drugs such as NSAIDs or steroids. Importantly, PPIs generally do not require adjustment of anticoagulant dosing. And among the available agents, Pantoprazole is often preferred because it has relatively fewer drug interactions through the CYP450 enzyme system. Finally, PPIs are also frequently co-prescribed with systemic corticosteroids. Although the evidence supporting routine PPI use with corticosteroids alone is somewhat limited, the risk becomes more significant when corticosteroids are combined with other ulcerogenic factors such as NSAIDs, advanced age, or a previous history of peptic ulcer disease. They are also considered the mainstay of treatment for Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is a condition caused by a gastrin-secreting tumor called a gastrinoma, which leads to excessive stimulation of parietal cells and massive gastric acid production. Moreover, PPIs are frequently used in the management of upper gastrointestinal bleeding related to peptic ulcers and also for stress ulcer prophylaxis in critically ill patients. They may also be used in certain patients with dyspepsia and are sometimes given before anesthesia to reduce gastric acid secretion and minimize acid-related injury if aspiration occurs. Now let's understand the dosing of PPIs. As you can see, PPIs are generally classified into low dose, standard dose, and high dose regimens. For example, Omeprazole is commonly given as 20 mg once daily as a standard dose, while Pantoprazole is usually prescribed at 40 mg once daily and Lansoprazole at 30 mg once daily. For most common acid-related disorders, such as gastroesophageal reflux disease and peptic ulcer disease, standard once daily dosing is usually sufficient. Meanwhile, lower on-demand doses may be used in milder symptoms, whereas higher or twice daily regimens are typically reserved for severe esophagitis, refractory gastroesophageal reflux disease, or hypersecretory conditions such as Zollinger-Ellison syndrome. These drugs are best taken about 30 to 60 minutes before breakfast so that the medication reaches the parietal cells when proton pumps are becoming active after food intake. Furthermore, in patients requiring twice daily therapy, the second dose is usually taken before dinner to maximize inhibition of newly activated pumps later in the day. In contrast, bedtime dosing alone is generally less effective. However, during H. pylori eradication therapy, PPIs are often administered together with meals and antibiotics to improve patient compliance and simplify the treatment regimen. Pantoprazole is also available in an intravenous formulation, particularly for hospitalized patients or situations where oral administration is not feasible. Now, although PPIs are generally considered very safe drugs and have an excellent safety profile, it is still important to understand their potential adverse effects and drug interactions, especially during long-term use. To begin with, the most common side effects are usually mild and include nausea, abdominal discomfort, constipation, flatulence, diarrhea, and headache. In rare cases, effects such as skin rashes, joint pain, muscle symptoms, or interstitial nephritis may also occur. Furthermore, since PPIs are metabolized in the liver through CYP enzymes, they can interact with several commonly used drugs, including warfarin, diazepam, methotrexate, and clopidogrel. Importantly, among the PPIs, pantoprazole is often preferred in patients taking clopidogrel because it has fewer CYP2C19 related interactions. In addition, prolonged suppression of gastric acid may reduce the absorption of certain nutrients and drugs, particularly vitamin B12, iron salts, magnesium, calcium, and medications that require an acidic environment for absorption, such as ketoconazole, ampicillin esters, and iron salts, thereby increasing the risk of iron deficiency anemia and vitamin B12 deficiency over time. Furthermore, some observational studies have also reported reductions in hemoglobin and hematocrit in chronic PPI users, further supporting a possible link with iron deficiency. Due to decreased absorption of calcium and vitamin B12 during long-term acid suppression, PPIs have been associated with an increased risk of osteoporosis and bone fractures, particularly in elderly patients. Moreover, long-term PPI use has been associated with an increased risk of rebound acid hypersecretion after discontinuation and a higher susceptibility to certain infections such as Clostridium difficile infection and hospital-acquired pneumonia. Chronic acid suppression can also lead to hypergastrinemia, which may cause enterochromaffin-like cell hyperplasia and fundic gland polyps, although the overall risk of serious malignancy appears to be very low. Finally, some observational studies have suggested possible associations between long-term PPI use and conditions such as chronic kidney disease or dementia. However, the current evidence remains limited and has not been conclusively proven by strong prospective clinical trials.